I'll pass it on over to you.
Yeah. So hi everyone, thanks for having us today to talk to you guys. So you guys may recognize us. If you went to the CTSI's boot camp, we were part of that too. So might be seeing us again. But today we're going to be talking about when things go wrong, managing common clinical trial conduct issues. So just kind of talking about doing, corrective action plans and, how to, address making decisions on how to report things. So this is us here. So I'm Beth Aselli. I'm the quality assurance manager in the Cancer Center Clinical Trials Office. So I've worked in oncology research for 20 years here at the college. So, and Marty and I have known each other for just about that long.
Same amount of time. Yeah, exactly. So yes, I'm Marty Gray. I am the education manager in the same department in the Cancer Center Clinical Trials Office. So yeah, some of you might recognize us from boot camp. Today we're just going to talk to you about, we can go to the next slide, guys, but just kind of some things like when things go wrong, right? What do we need to do? And sometimes I think first you need to not panic and just really walk through it. First, recognize what the issue is. So we're going to talk about some common issues that might come up during clinical trial conduct. We'll talk about what you need to do. So again, don't freak out, recognize it. What are the immediate actions you need to take to respond to it? We're also going to talk about why we need to do that, right? Because at the end of the day, when we're doing clinical research, we want to protect that participant's safety. That's always at the forefront of our mind. Oh, sorry, I'm like that, but yeah, and maintain that data integrity. We're also going to identify when you need to report to the IRB because not everything needs to go to them immediately, right? So talking about reporting to them, maybe your sponsor or any other bodies that are overseeing your trial, and then also do you need to develop a CAPA? So a corrective and preventative action plan. Not every single thing that goes wrong is going to require a formal response like a CAPA. So yeah, those are the objectives. So to dive deeper to why this matters. So again, we want to make sure we're keeping our participants safe. So when we identify issues, that's one of the things we want to think about is how does this affect the safety of a participant? We want to protect their rights and welfare. Also, the whole point of what we do in clinical research is to get generalizable knowledge out into the world, right? And the only way we can do that and for people to trust the information we're putting out in the world is to make sure we have integrity in our data. So that's the other reason why this matters. And also, obviously, if you're having issues, making mistakes, that can lead to like regulatory findings, concerns by your sponsor of trial conduct, increase your monitor visits and audit findings, and also just an overall loss of trust, whether it's by the sponsor or by the community in which you're doing that research. So not to say that mistakes shouldn't happen. Errors happen in every single research program. We always say the perfect trial has yet to be written and the perfectly run trial has yet to be done. And, I have some QA background, that is her jam. And if anything, if we do a QA review and don't find anything wrong, that actually makes us more concerned because we're human doing human participant research. So the difference is how quickly do we recognize when things go wrong and how effectively do we respond to them?
So we're going to talk a little bit about kind of like our clinical trial, kind of like our problem, our first response plan that you should be doing. So first of all, when you identify something that has not gone well, you want to stop, assess what happened, you want to act upon it, you want to report it, and then we want to prevent it from happening in the future. And you really kind of want to do it in that order. So first stopping, recognizing that something may have gone wrong. If you feel like suddenly you're recognizing a pattern of things, talking to someone about that, being like, hey, I think this might be a problem. I think this isn't going right. Or you might say, I just looked at this protocol and I realized I think I've been doing this wrong for the first few subjects. So just stopping and assessing it. So assessing it, first and foremost, were any participants put at risk? Were their rights and welfare affected? Is the data integrity impact? So just kind of doing an impact analysis on what this issue has impacted. So then taking that immediate corrective action. Do we need to do something to assess the patient's safety? Do we need to, do we need to talk to the investigator? Do we need to talk to the sponsor? Did we realize that we think there might be an error in the protocol that we need to talk to who wrote the protocol, something like that. And then reporting these things appropriately to the IRB, to regulatory authorities, to the sponsor, whoever needs to know about these. Do we need to report to the patient? So something that happened. And then we need to stop and think, how are we going to prevent this from happening in the future? And doing, a CAPA. Even like Marty said, not everything requires like a formal CAPA, but you do have to kind of go through those same steps. And the three parts of the CAPAs are finding the root cause of what happened. And that's like the most important part. It's like digging into why this happened in the first place, because you're never going to be able to prevent it from happening in the future if you don't even know why it happened. So it's very important to look at that. So the first thing we're going to be talking about here is informed consent errors. So we have like a few examples we're going to be going through here. Again, as you all know, there's probably a million different things that could possibly go wrong in a trial. But we're going to just go over like a few examples. But the good thing about the few examples we're going over, we're going to kind of go through the same process of assessing things so that you can really take those actions and apply it to whatever problem you've encountered. So for some common informed consent errors would be expired IRB approvals, a wrong version of a consent form used, missing participant signatures, missing the person who's obtaining the consent, missing their signature, incorrect dates written. This happens a lot in the new year. Suddenly it's 2026, and in January everyone's still writing 2025. Participants signed after the procedures have already occurred. Some procedures have already occurred. Assent and parental permission issues that you're having for pediatric trials, missing a HIPAA authorization, and then perhaps like a second study or a sub-study consent that was not, given at that time. So again, for any of these things, we would use our first response, and we would stop, assess, act, report, and prevent. So
to help us apply these, Becca said we're going through some examples. So this is the fun interactive portion of today's training.
Entertain us and answer, so we're not just talking to ourselves here, but we will do that if we have to. So
I'm really good with silence.
Want anybody to speak up like as you go through these, because I saw you like post questions throughout. Do you want people to just unmute?
Yeah, they can unmute.
We probably won't see the chat. Please unmute. I'm not sure we're going to see the chat unless I don't know.
There is managing it.
So as we go through, if you want to drop things in the chat, you can also shout it out in the room or unmute yourself.
Yeah, and we're going to kind of go through these a little bit. We can't wait for 5 minutes in between every question to see if you guys are answering. So let's hop to it a little bit, but because we only have an hour, so just we can kind of rapid fire answer some of these things. So go ahead.
All right, so here's your scenario. A coordinator printed a consent form from a shared drive that contained an expired IRB approval. The participant signed that outdated consent and completed study procedures. So we know that we need to do our workflow. So we need to stop and we need to think about what are our immediate concerns and what would you do first. So it's kind of like that stop, assess, and act. So what do you think you would do? What is your immediate
what's
concern?
The biggest concern with this? Like big deal, the date's different on the consent. Like what is the concern with that? Yeah, go ahead.
There's something on like the new consent form that wasn't on there previously. It's like, okay, well, we didn't consent to this part now, so what are we missing?
Right. They weren't truly informed, right, about what their participation was going to look like.
Yeah.
Exactly.
So there could have been new risks. There could have been new procedures. You went forward with a procedure that was added in the last amendment, and now they didn't actually consent to that. So yes. So anyone else?
Any other concerns?
And then
what would you do?
What should we do? So anyone, feel free to yell.
If it was something where you'll see them again at a future visit or can get in contact with them easily, I would try to reconsent them with the correct version and then just document that procedure properly.
Yeah, so if you couldn't hear it online, she said, get in touch with the patient at their next visit, get them to sign the correct consent, make sure they're informed of maybe what those changes were. So maybe if we're not seeing them, maybe they don't live nearby, we're not seeing them, maybe informing them of like, hey, this was in there, these additional risks, you didn't sign that version, But we want to let you know because this is something that could impact their decision to participate. And then not only are you going to have a conversation with them, what else are we going to do?
Who do we need to notify?
Yeah.
Notify.
We have to document it, right? We shouldn't be having this conversation and then have this be living in your memory. I mean, this should be documented, right? So we do, yeah. So
And I'd love to address the notify. So we're getting close. So the documentation part. So I think a lot of people get confused. Oh, sorry. Is there a question?
Yeah, go ahead or chat.
Oh, it's
No,
okay.
go for it.
The question is, why is the consent in the shared drive not being updated?
Okay. So now we're getting to root cause.
Yeah.
Oh, yeah.
Yeah.
Yes. Very good.
Cliffhanger. Hold on for that
Yeah.
answer. I know it's super exciting. So we were just talking, oh my gosh, my brain, I feel like we're like a comedy duo today, but like, so we were just talking about who are you going to report to? And then I think Christina was mentioning a note to file, but when we say who are we going to report to, again, who are we going to report to? Potentially IRB maybe. So if we're going to report something in the IRB, we don't need to do a note to file because that is our documentation of it, right? So I know a lot of times like note to file should be really quite rare. So just think about that component.
You could do a telephone encounter or
Yeah.
something, something like that. Like a progress note or something documenting that conversation with the patient. So,
Right.
But yeah, the documentation of what actually happened can be contained in that IRB submission. So yeah, but always better to document more, not enough.
So the immediate actions, we've discussed a lot of these already. So you guys did a great job. So some of the ones that we've already identified was determining if there are new risks or procedures, information that was omitted. We talked about contacting the IRB. We also, I think, talked about contacting the sponsor. We talked about reconsenting. We also talked about documenting thoroughly. So some other things to think about is to verify what procedures have been done, right? And compare that to the consent form that they had signed. Because if there was something like maybe a research sample you collected and they didn't consent to that, that's kind of a big deal, right? Because we need to talk to them about it. That needs to be in the report. And we also need to make sure we're notifying the PI as well as to what happened. And then with that IRB component, you're going to want to make sure you look at your IRB records. So I know that some of us have local MCW IRB overseeing it, but do you have a commercial IRB or a central IRB? Their policies might be a little bit different. So look at that criteria to know what you need to figure out from this situation in order to determine reporting. So,
and I think what Marty said too about notifying the PI, it's really important. It feels like everything's delegated to like somebody else. And it's like, okay, what are they in charge of? Well, they are still responsible for everything. So if there is a problem, they need to be in the loop about it and need to be making decisions about if they believe something is reportable immediately to the IRB or with the CPR or, patient safety concerns, they need to be in the loop about that. We can't be making those decisions without their involvement. Now, sometimes these might not be easy conversations and you're telling them that you screwed something up and it's like, but that is hard, but it's like, it is their trial and that is really important.
Sarah, I think
there was one other comment that came in, I think during this slide, it says follow up and is this isolated to one participant?
Oh yeah, that's a great point. Oh, that's a great point.
Yeah, great point too. Yeah, so that impact analysis.
Yeah, oh shoot, did we do this with another participant, not realize it? Yes, that's a great point.
That's a good question. Yeah, I think where I get like stuck too being so new is like, how do you know when you need to notify sponsors? It just isn't required. Like,
yeah. So great question. So what I always tell people is like, look at your protocol, right? Because your protocol is going to tell you if those things need to happen. But also was someone trying to say something online?
Oh, yeah. Okay. It was an agreement.
Yeah. Okay. I was like, is someone trying to talk? Yeah, I know. So yeah, protocol always. And also go to your manager. If you're questioning things, like hopefully you have some type of support system to help you go through that. And I would always say, go to them and don't just say, what do I do? Talk through your thought process. Like, okay, this is what happened. I feel like this is what I'm supposed to do. Am I on the right track? Right. Yeah. So don't just like throw your hands up and just ask for help. Unless you're really that lost, that's okay too. But try to think it through. Go to your manager, wherever you might have, or a veteran person.
And also going to your sponsor and saying, do you need me to notify you of things? This just happened. Do you need to notify these things? Be notified of these things? They might say yes. They might say no. Just to follow your institutional process. It's kind of different. We have a lot of different sponsor types, and like it can be different. for each
And
one.
I know you have a question, but real quick, based on what Becca said, that last bullet point can't be stressed enough, document thoroughly. So for example, your question of, do I need to report this? If you end up talking to your sponsor and they say, nope, we do not need to know about this, get that in writing.
Follow
right?
up with an email per our conversation. You said those need to be reported. I just wanted to make sure you were aware, but you said these don't require direct reporting, whatever.
So make sure
Yes.
that's documented. And then I think she had a
I mean,
question.
it's kind of similar, but like with reporting to the IRB, like certain, depending on if there's a version difference that was major in that, I always like go to the IRB coordinator to ask like what they prefer for like, is it a reportable event or just something that can be reported as for investigation? And I
And too, a lot of times what they'll say too is like your investigator should be using their knowledge and our policies together to make that determination. And so that's usually what they direct us to do. Like, I mean, because again, they don't know necessarily the patient population, they don't know like the impact, like the safety impact usually of, potentially things like that. So they really do rely on the study, PI to make that determination using their knowledge. So yeah, thank you for all that interaction. We have 4 more minutes.
Yeah, that was
So,
great. Yeah.
and then I don't know if you want to go to the
Yeah,
so
so
preventative things.
when you're thinking of how we're going to prevent this from happening, there's a couple different things. And Becca said you need to get to the root cause, right? So this doesn't necessarily start with the root cause. We will talk about that actually a little bit more in a second. But depending on why it happened, someone mentioned like, why wasn't the most current version in there? Or maybe it was in there, but it's poorly organized. So it's hard to tell which version is the correct version, right?
Were they not even supposed to get it from the shared
Right,
drive?
exactly. Were they not following the correct process to obtain it? So depending on what the reason was, some potential ways to prevent this was maybe we need to print that consent form directly from eBridge or Florence, right? Maybe you guys need to create a guideline or an expectation in your department of how you're going to obtain the correct version every time. Maybe instead of having people like pull from that local drive because we need to save them for our records, maybe we archive them. So we archive all the old ones so they know exactly these are all the old ones, don't go in there. Maybe that's something you do. Staff retraining, right? Maybe you do have a process and they just didn't follow the process. So you're going to want to retrain them. Maybe you create a checklist when you're consenting. And on that checklist, there is verify that you have the correct, most currently approved version, or maybe there's a double check process too. Maybe before you go down to consent to patient, you have to have another coordinator double check that you have the right version. So there's so many different things you can do. That being said, we'll get into it more, but again, document. So document like what you're going to do, but also document that it's been done. So if you said you're going to retrain your staff on your workflow to pull the most current version, like, well, did you do it? You said you were going to do it, but did you do it? Can you prove it? Right. And if it wasn't documented, it didn't happen. So,
yeah.
All right. We'll go on to example 2.
Good. Okay. So this actually, I feel like we can get through this one kind of quickly because this is a similar issue. But so this one, you've actually just used the wrong study consent completely for the wrong study. You have 2 studies that have a same sponsor, they have very similar titles, and a participant was consented to the wrong study. So our discussion questions here, what do you do with the wrong consent? This patient signed a consent that they were not supposed to sign. Do we stick it in the shredder and forget it ever happened? Luckily, I've not seen anyone nodding in here. So have we done any study procedures yet? So what do you think? So what do we do with that consent form? I mean, it's a rough one. Yeah. Do we shred it? Do we keep, first of all, do we shred it or do we keep it? We keep it. Yes. No matter what, you never like get rid of a consent. Even if you were like, shoot, this was the wrong consent. You don't just get rid of it. You do have to keep it. This is part of, this patient's story here. And then also when did we find this out? Did we realize this 2 seconds left? Did we realize this after we did a bunch of study procedures for the study we thought we were consenting them for? So yeah, this kind of stuff does happen. We have lots of studies that have the same sponsor, and it's easy to just click on the wrong one, so this can happen. We actually had this happen one time to a patient that they called their name in the waiting room, and they had the exact same name as another patient that was gonna be getting consented, and this patient was so confused about the study, and we realized it was the wrong patient. So, yeah, they signed the whole consent and everything.
No,
They were
they
like,
went through
I didn't even know I had this disease, and we were just like, okay. So, yeah, we had to implement some corrective action about checking two identifiers and not just the name. So, okay, so immediate actions here. What should we do here? So we should assess the participants' risk. Did they do any invasive procedures? So, obviously we have to notify the PI, report to the IRB per the policy. To me, this would probably be reportable. Again, you make that determination with the PI. Notifying the sponsor, notifying the other sponsor if it's a different, probably if it's that similar of a study, it's probably maybe the same sponsor, but making sure you're notifying everyone about what happened. Evaluate what data should be retained. Should we have screening data for this patient that consented? We're gonna have to work with the sponsor closely on that because they weren't even supposed to be part of this. Documenting the deviation appropriately. So what do you think then, if we're looking at corrective actions, what do we need? How do we figure out like corrective and preventive actions? What ideas do you have for that? Like if we're talking about like preventing things, like what should we look at for that?
Wonder about the mismatch between, protocol procedures from one study to the next, and does whoever's getting informed consent need to be re-educated about what the study protocol is that they're going to follow? Like, why did they not realize right away?
Yes. First of all, it's like you have to look. How did this happen? Like, I know there's similar names and stuff, but it's like if this was such an easy mistake to make, like, how are we going to prevent something like that from happening again? What did they keep them in a file drawer and they kept the wrong consent in the wrong file system or something like that? I don't know. So again, we always have to look at that root cause. We can't prevent this from happening in the future if we don't know why this happened. But again, examples here, and if anyone else has anything, please just yell them out. But maybe making an amendment to the study to make that short title clear on like the cover of it. Maybe there's something that you could indicate on the cover of that consent form that would make it more clear. Maybe you could utilize like a color coding system, something like, I don't know, or just like a more distinct short title. Maybe you bold certain like words or something like that to make it more clear. Maybe you have a consent verification checklist with that double check process where you have to double check like the PROs match each other or something. Creating like a tip sheet. So typically a good CAPA is not just re-education, it also has a double check component to it. Maybe that double check is like double checking that you have not done this for any other patients. Maybe it's creating some sort of double check checklist or something that your coworker might be checking. So
they said the audio is a little
Oh.
choppy, so
Oh.
maybe I just
We do have to go by the-
we thought maybe they could stray a little bit.
okay, we're getting close here.
Just a little bit.
Okay.
And then if you could just be a little closer.
Okay, sounds good.
Thanks for the feedback, guys.
So some common issues. So before Becca goes to the next portion, we're talking about protocol deviations. So again, it's interactive. What are some protocol deviations maybe some of you have had in your trials?
Like just like general things.
Missed labs. Okay.
Yep. What else?
Imaging.
Oh yeah, imaging done at the wrong time.
So outside a window.
Yeah.
Patient was changing insurance and had to get an appointment outside a window.
Mhm.
Okay.
Yeah. So appointments outside a window, very common.
Mhm.
What else?
We can go to the next ones because that is pretty much like a lot of the ones that we tend to deal with, right? Maybe things being outside visit windows, missing, procedures, but oftentimes eligibility, them not maybe meeting eligibility completely, or you missed like one little bullet of like the 15 to 25, pieces of eligibility they had to meet. Maybe there's something wrong with the administration of the treatment. Maybe it was infused at too high of a rate, or maybe the dosing was off. Safety reporting wasn't followed, right? Maybe you had to report it within 24 hours, but you reported it in 3 calendar days. Study procedures missed, and then investigational product accountability. So maybe even say like maybe you are giving out oral pills to a patient and you gave them 30 pills, but it's February, so they were supposed to come back with like 20, with 2, because they should have only taken 28, but they come back with 0. What happened to those 2 extra pills they were supposed to have? Did the dog eat it? Did they take it? We need to account for that, right? So again, these are some common issues. And anytime you run into that, you're going to stop, assess, act, report, and prevent. So deciding how to report. So things that you need to ask yourself, does this affect, this is going to be very similar to what we talked about. How does this affect participant safety, their rights, their welfare, data integrity? Is this immediately reportable? Again, you want to check both your IRB policy and your protocol, right? Because they might tell you different things. What corrective or preventative action do you need?
So who can chime in here with our local IRB's policy for requirements for reporting immediately versus with the CPR? Like how do they make that determination? Does anyone know that off the top of their head for a deviation? Like what is it, like what criteria do they say that is planned or
cost harm mitigation?
Well, close.
Sort of, yeah. That could be one thing. Yes. So they use it. Yeah, they use like a term that they call significant. A significant or planned protocol deviation would go, and it is usually something that is going to impact the rights and the welfare of the patient, their safety, something like that, that's like impacting safety. All the other things that we would determine perhaps are not, impacting the patient safety, that can all go with the CPR. But sometimes it's like, as we know, not everything's always black and white. You really sometimes need an investigator to weigh in on these things.
And I just wanted to mention, I don't know if people online could hear. So one thought was, did it harm the patient or the participant? And I just want to point out, just because the participant wasn't harmed doesn't mean it's not immediately reportable. It could have still increased the risk or increased safety concerns for that participant. Thank goodness they didn't get harmed, but it's not just whether they had an infusion reaction or not. Was their risk increased? So that's something we need to think about. So we're going to go into a couple examples. And so Becca's going to go through one right here.
Okay. So our next example here is a visit that's outside the window. So a 12-week assessment occurred 10 days outside of the protocol defined window because the participant was traveling. So maybe they gave a 1-week window and now it's 10 days outside of that window and they were traveling on a vacation. So now we have a deviation. So kind of some of our discussion questions, is this a deviation? I mean, we're talking about this as an example. So I would think our answer would be yes. Okay. Yes, this is a deviation. So some people, this is a common mistake. I feel like I hear newer coordinators say, well, yeah, but I didn't schedule it wrong. Like the patient did this. Like it wasn't me. It doesn't matter whose fault it was. It doesn't matter if the patient refused to visit. It doesn't matter. That doesn't matter. It matters that it didn't follow the protocol. They were supposed to be seen at this time and it didn't happen. Whether there was apocalyptic blizzard here that you absolutely had no control over whatsoever. If it meant that their visit fell out of window, that is unfortunately still a deviation. So what do you think should be documented around this? Like what kind of documentation do you think, if you had a patient in the scenario, what do you think we should, if I was an auditor, what would you think I'd want to see documented surrounding this? Feel free to throw it in the chat, yell it out.
Maybe think about some of those components we just talked about that tell us whether it's immediately reportable or not.
Like, did we even try to get the patient on the schedule, like correctly? Like at least did we talk to the patient about when their next appointment was going to be? Did they even know that they had an appointment at the 12-week mark that they could have, I think it's just like showing effort around doing this. There are some things you cannot change and there are some things that you cannot help. And there are going to be patients that have the best intentions of following the protocol, but maybe you have delays for certain reasons. And now that visit falls square in the middle of their trip to Bermuda and they are not changing it. So sometimes we can't change, but it's like, does it show that we made some sort of effort? Does it show that we communicated to the patient how important it is to stay on track with this? And even though they're not going to change it, did we at least still communicate that to you? It's really important to keep on track, but we understand you have this, so just having some documentation. Does it show that we made any sort of effort? So does it show that we also made an assessment to see if this impacted patient safety? Are they going to be without their drug for 10 days? That is potentially like a life-saving or drug for them. Is this drug that they're going to be without for 10 days going to be something that could impact their health? Could that put them at risk not being on that drug? Maybe it's something to control pressure or something like that is important. So those types of things. Yeah.
8, notify the sponsor if applicable, and notify PI, assess if there are any safety evaluations are being done at W12.
Oh, week 12.
12.
Yeah,
Oh,
week 12. Yeah.
And
Yep.
I was like, when I,
Yep. So yeah. And we're all sitting here like, what is that? Yeah. Week 12. Yeah. So yeah, very good. Yeah. Those are all great points. Like, is there anything we could do beforehand to kind of like, at least kind of mitigate this? Like, could we make, if they do need access to their drug during this time that they wouldn't normally get it and they wouldn't normally get it refilled, is there a way we could orchestrate that they get an abbreviated supply of the drug? Is there a way that we could check in with them somehow, during that time to mitigate any safety risks? So just any effort that we could make to not just be like, bon voyage, hope you live, it's like, we want to make sure that we're at least making an effort to monitor their safety, making sure they're safe, making sure they know how to get a hold of us if something does happen, making sure they know where their closest hospital is, their closest ER is, even if they're, traveling somewhere. So, and what to do, sometimes when patients are traveling, we tell them, make sure they call this hospital if you are inpatient, or make sure you don't get this certain drug. Sometimes we can't be giving patients steroids and things like that. So we tell them these things, make sure if this happens, they don't give you this, and make sure you tell them that. So that's important that we give those instructions.
So just a comment from online. This isn't just like a research issue. Especially if there are safety evaluations, the PI or the doctor whose medical license this is under has the duty of care to monitor this. And so, it's not just following the research regs, it's also medically caring for the patient.
Yeah, absolutely. That's a great point. Yes. I mean, it's like I said, like if this is like something that this is treatment they need to care for them in a medical sense, this is their obligation. So yes, that's a great point. So it's not just like, oh, well, they're on vacation and you don't have to do anything. There's nothing I could do about it. You actually do still have to think critically about, is this patient going to be safe? And how can we safeguard that? So, and then also like, okay, should we have gotten this approval from the sponsor? I mean, how long ago did we know about this? Did we make an attempt to even talk to the sponsor about like how we should manage this? Have they gone through this before? Do they have a process for something like this? So instead of blindsiding them after the fact, we should be involving them in those conversations. So so like we just talked about, review the protocol flexibility. Is this actually a deviation? Determine whether prospective approval was possible, notify the sponsor, document in the EMR, submit a deviation. And then we also talked about maintaining that subject safety, making sure if there's anything medically we need to do to them to keep them safe. And then the corrective actions. We could utilize a window tracking tool. So, visit planning calendars to forecast these visits. So if the patient's looking to plan a vacation, say, hey, if you're looking to do something like this, let's forecast when your visits are going to be, and let's see if we can do without impacting the protocol. Usually patients are very happy to work with you to do that. Making sure that early communication with the participants, when you're consenting that patient, talking to them about how important it is that we stay right on track with the protocol with that militant precision. And then potentially, sometimes depending on where they're traveling, sometimes we've even arranged for patients to be seen at another site that has this trial open, and to just, again, do everything we can to maintain that integrity of the trial, the data, the safety of the patients, all of that. And like I said, sometimes these things just like cannot be prevented. And sometimes, you have patients, we work with patients in oncology. These are sometimes, these are the worst times in their life and they want to go on a vacation. And it's like, we want them to be able to do that. And we want to just help them do that safely. So, okay, another example.
Yeah, so this is your new scenario. After enrollment, staff realized one required lab value obtained prior to registration was outside the eligibility limits. So, what kind of questions we have? Does the participant have to discontinue this trial? What do you guys think?
Check their protocol. Are you allowed to rerun labs? So how many times?
So check your protocol is the answer in the room here. Yeah. So Any other thoughts on that?
Yeah, and the sponsor about whether this posed additional risk.
Mm-hmm.
So I
Yeah.
don't know if people could hear on the phone, but they said, talk to the sponsor and your PI to see what their thoughts are.
So it's not a cut and dry answer.
Yeah.
The short answer is it depends.
Yeah.
So,
What kind of
yeah.
lab was missed
Yeah,
as well,
what,
right?
Yeah, what was the eligibility issue?
Yeah.
So.
So what should be documented? Any thoughts?
Any communications to determine if they
Yeah,
keep them or.
absolutely. Sure. So if you're reaching out to that sponsor or if you're talking to the PI, you want to document that conversation, right? You want to document also what went wrong, right? Which lab was it? When did it happen versus when it was supposed to happen? When did you find out? Are they now have been on the trial for 6 months, or are they still, in screening? That's probably important to let people know. And then what factors will influence next steps?
Yeah. So we kind of talked about this a little bit.
Yeah.
But like what would depend on if we're going to potentially take the patient off, whatever, what kind of factors would go into that? We kind of talked a little bit about this, about just if does the patient have the right disease for this trial? Do they belong anywhere on this trial? It's and then if it was just one missed lab value, did we ever draw that lab value? Do we know if that lab was ever in range? Do we know if how far out of range was it? Was this at a dangerous level, or was it one little notch outside? So again, so really a lot of times safety will determine that, safety, and then of course data integrity as well.
So if you have this scenario, the next steps will be, so we can go to the response one. So things that you're going to want to do is obviously notify your PI, right? Because we want to talk to them oh my gosh, this happened. You want to also kind of talk to them were they truly eligible? I don't know, did they have a similar lab done? Can we get it done in time? We're going to assess that participant safety. We want to contact the sponsor, determine whether treatment may continue. We just talked about all these things. Report to the IRB as required. And again, always document very thoroughly.
So again, I know we sound like a broken record with this, but it really is the same steps you kind of take every time. Involve your PI and assess the patient safety, decide how to report this, and then of course we have to decide how we're going to prevent this from happening again. So maybe before we go to the next slide, what do you guys think as far as corrective and preventative actions? How could we prevent something like this from happening again?
So as a reminder, we drew a lab sample or got a lab value that was out of window for eligibility. So how are we going to prevent that?
I think it was out of range. It was out of range. One required lab value obtained prior to registration was outside protocol eligibility.
Oh, protocol eligibility.
So I think the value, we got the lab drawn, but it was let's say their platelets had to be 100,000 to be eligible, and their platelets were 10,000. So they were outside of the limits to be eligible. So how would we prevent this from happening in the future? So yeah,
Kind of double check, or within the checklist that you have exact range, and then you have to write it down next to it so you can really see exactly what it needs to be.
Yeah. So just for those online, so they're saying a double check, whether it's having to document what those values are right next to your eligibility, or maybe a double check, meaning someone else has to look over it as well. So 2 people have to confirm eligibility maybe before they go on study.
That is one thing in our department we are adamant about, is eligibility checklists. If it says this value must be this, you write that value down, because sometimes they'll say oh, the patient's performance status has to be a 0, and you're oh yeah, I remember the patient being totally fine when they walked in, but it's so then they just check, but it's and then it's okay, but was that actually documented anywhere? So writing down the value, we tell them write down the value and the date that you saw that in the note, because then you'll know you actually looked at it. And same with this value, write down the value and the date that you got it, because then you'll know you actually looked at it, then not just oh yeah, I remember their labs were all good, check, 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 check.
So we basically talked about that. So on the next slide, we'll talk about, what we mentioned for CAPAs. And so we really just went through most of that. I think did we go back?
I went back.
Yeah, sorry.
I'm sorry. Yes.
So yeah, writing notes on the eligibility checklist, having a double check whether that's before, you decide they're eligible, or even at registration, having that second view, making really
checking too.
Yeah, we do a double check in the cancer center. I mean, we have like eligibility checklists that are like 5 pages long. Sometimes, I mean, they're very long, very detailed. So we have a secondary review on every single eligibility where we have a coordinator check it, a backup coordinator check it independently, and then we have the enrolling physician also sign off on it. So we have like 3 sign offs on any eligibility. So
Even something I've seen, because I'm on 3 different teams in the cancer center. The one team I'm on, like mainly, they like copy and paste it essentially into their own document, and then they have to write like a blurb of here's where I found this eligibility, here's the quote from it. So it's like you know exactly where to go back to. And I feel like that was good to see, because it's like, hey, if somebody does come and question you, it's like, no, this is exactly where I found it.
yes. It reminds yourself too,
Yeah.
because like if you're looking at this with an auditor 5 years from now, it's like, okay, where did she find this? You know, it's like, this is, and that is really helpful rather than just having a bunch of checks on a page. It's like, okay, that's nice that they're checked off. But when you write it on there, that really shows like, I looked at this. So.
One last example.
Okay, so one last example here, then we get to talk about the wonderful world of CAPAs for the last 15 minutes. So, okay, so medication administration error. So again, this could take many forms, but we have an IV infusion here that was given to the patient at the incorrect dose. So that's all the information I'm giving you here at this point. So obviously there's a lot of factors that would impact this a little bit, but first of all, what is your first priority here? Patient safety. Is the patient safe here? You know, again, the dose, you know, it really impact this. Was the patient supposed to get 4,000 milligrams and they got 4,001? Well, that's a different scenario if they were supposed to get 4,000 and they got 40,000. You know, that's a really, obviously that's what you have to kind of look at, but making sure first and foremost, was the patient safe? Is the patient being taken care of acutely? Who should be notified? Who should you bring into this conversation?
PI sponsor right away.
PI sponsor right away, first and foremost, yes. And so who else? So now you've done that initial notification of the PI and the sponsor. Who else might need to be involved in this? Maybe like the IRB.
Pharmacy.
Pharmacy. I would say who's administering the drug here too? Like who? So the pharmacists who you know mixed up the drug, and then where did they get the dosing from and all that, you know, so and then who infused the drug, you know, was there anyone else who did any sort of double check on the dosing? If the treating investigator was different than the PI, making sure they were aware of this, you know, so yeah, very good. And then so we just talked about our response here. So ensuring participant safety, notifying the treating provider and the PI if not already aware, assessing for AEs and SAEs and reporting those as necessary, you know, obviously involving the sponsor, submitting a deviation per your policy here for your IRB or institution. And then, of course, then like really within that deviation, you're going to want to assess that root cause. So what are some of the corrective actions that we could take then that would be, you know, depending on what the root cause is, right? So any thoughts on that, on corrective actions? Or preventative actions, I guess I should say too. So
Again, a double checking procedure, you know, wherever drug is coming from, pharmacy, whatever that handoff procedure looks like. Is there some kind of like a sheet that you can have to confirm dosing, you know, all the other criteria that.
Yeah. So you have to look like, where did this dose come from? You know, like where did this dose come from? Is there a double verification process? Who wrote the orders for that? And where did they get that from? You know, so we should have a pretty airtight, foolproof process here for dosing patients. I mean, you can't just move a decimal point and then infuse it. You know, we need to be able to have a good process in place then. So we use a program functionality within Epic called Beacon. That's just our order sets that are in there, medication orders and all those things surrounding those medication orders. So looking, was the plan correct? Were the orders that are in our plan correct? So having, like you said, an independent double check, and then some sort of pharmacy communication process, perhaps. You know, so again, depending on the root cause of the issue, how we can figure that out. So All right.
So moving on, so we've been talking about kappas a little bit, but they are a fine art form, I will say. So if you have to write a kappa and you've never done that before, the PP office has a quality assurance team, and they're more than happy to help you write those if you don't have someone on your team that is used to it. So we're going to talk about the art of kappas and the things you need to think about.
And after this, you guys might be the experts in your department on
right?
writing kappas.
You're welcome.
You're like, I got this.
Yeah. So we've been talking about this a lot, but if you don't walk away with anything else, we want you to think about root cause analysis. Why did this happen? And keep asking why. Don't ask it once, and we're going to get into that in a second, but why did it happen? Again, it happened. Why? How are we going to correct it in this moment? And what are we going to do to prevent this from happening again? So those are kind of the three components you really need to think about. So when we're saying why, it's not just why did it happen? Sometimes you might have to go a little more in depth to get to the true root cause. So, for example, a deviation occurs where a research participant's research lab samples were not submitted to the sponsor per protocol.
Now, I'm just going to interject here, and I'm just going to say sometimes we see things. I work in quality assurance, and we see deviations that this will be the deviation, and then they'll say every effort will be made to send the samples on time. And it's like, okay, but like, have you even tried to figure out why this even happened? So so that's what we want to make sure we're looking at here.
So we might say, well, why? Why were those samples not submitted per protocol? And we might end up saying, well, the labs were not drawn on the required visit date.
Okay, so it makes sense.
So
like,
yeah. So that's,
okay, we didn't send them because we didn't draw them, right?
Yeah.
But then
why? Why were they not
were
done
they not
on that visit date? Yeah. So maybe in this scenario, the coordinator did not coordinate the labs.
Okay, so they weren't sent because they weren't drawn because the coordinator didn't coordinate that lab draw. Okay.
So why didn't the coordinator do it? Right. So we're gonna go through 5 levels of whys, as it says in the header.
5 whys.
Yeah. So the coordinator didn't know that the labs are required. Okay. So that also makes sense.
Yeah.
But why did they not know that?
Why didn't they know?
So the coordinator did not realize the study labs were outlined in a section of the protocol separate from their schedule events. So this is an issue we see very often. A lot of people like to use that schedule events, especially if you have a more complicated trial, right? It's just a nice one-stop shop where you can see everything, but maybe it doesn't include every single little thing that needs to happen. So don't just look at that calendar of events. Make sure you're reading the full protocol, and especially that procedures section, right? To know exactly all the procedures that are expected and the timeframes for your whole study. So the coordinator was just looking at that schedule events. They weren't digging further into the protocol. So the last why did they do that? The coordinator took over the study without completing protocol training and reviewing the protocol complexity. So that is our root cause, because they did not get proper training, right? So that's our root cause. That's our why.
So yeah, we don't want to just say we just didn't send the labs and we'll try better next time. We can't prevent something like this from happening if we don't know why. If we don't know why it happened, then we can't help them. And the thing that auditors see that is always concerning, and me doing, our team doing internal QA checks, is when you see the same deviation over and over and over and over again, and you're just not seeing any improvement in that, and then not making any additional efforts as to why that, or as to try to help that. So we talked about, root cause, that's like the 5 whys. First we have to get to why, then we have to correct it and prevent it. So developing a corrective action is the immediate steps taken to contain and resolve the issue. Now, not all issues can be corrected. If you forgot to draw a baseline sample, like a pre-dose sample, you're supposed to draw a baseline sample before the drug infusion happens, and you forgot, now the patient got the drug infusion, you can't correct that by drawing it later. You have to have it done before they start, because they might be looking at levels of drug in the patient's system. You have to have that baseline. So not everything can be like corrected per se, like if you forgot to give the patient something for the study, like their drug bottle, you can have them come back and get that. Like you could correct that. But if you forgot to do something, like you sometimes you can't correct that. So, so an example would be asking the patient to come in for a missed visit at the first available opportunity, providing the patient with necessary information at the first available opportunity. Samples forgotten in the freezer, then as soon as we realized that we forgot to ship those, they were shipped out immediately. You know, these are things that can still be fixed. So, but like I said, not everything can be fixed. You know, so, and then we have implementing preventative action. So these are the steps. This is the really important part where you're implementing how you're going to prevent this from happening in the future. So this is again why that root cause is important. So, so don't overpromise on your CAPA. You have to make something that's doable. You don't want to say, now we're going to implement this humongous big change and it's not something you guys are capable of doing. Or like in our office, we have like 200 people in our office and we have to make sure that like everyone is on board with this change we're making. And you don't want to like be promising like different things for different studies because that gets way too convoluted. You really do want to be thoughtful about these things. Like it might sound good to like say, hey, we're going to implement this double check system for all of our protocols, but that one sentence is a lot of work. So you need to be very thoughtful of that. So, and then, so like I mentioned this before, but typically a good preventative action plan is going to have two components, re-education, and it's going to have some sort of double check process. So here's an example of a preventative action. So the study team was re-educated on 41025 on the importance of source verifying all eligibility criteria prior to enrolling. A checklist was created to ensure no steps were missed in the enrollment process, and the team was educated on the use of this checklist on 41625. Documentation of the re-education has been placed in the regulatory file. So we always say too, if you're ever submitting a reportable event or you're doing a deviation and it says you will re-educate them, you should have that education right in there with it. And you know, it's a mistake you only make once when an auditor says, so where's that education? You're just like, I don't know.
Who attended the training?
Yeah, who attended that training? So, and again, I mentioned this before, preventative actions shouldn't be created on an island. You need to like involve your leaders in your area, other teams that might be impacted by this, and make sure that they are on board with this new plan, because this can quickly get out of control when you have preventative actions and all these different things you're implementing, all these different processes, and you don't want this team doing it differently than this team, or this person doing it differently than that person. You don't want to write a preventative action plan just for yourself and now you are like the only person doing this. Like sometimes when we implement these things, we're like, this really needs to be like a office-wide change, and we vet those things and see what we need to do. That's why it's important not to overpromise, and also involve like your leaders to be like, does this need to be like a system-wide issue?
So with CAPAs, I'm just going to recap. Sorry. So you want root cause, corrective plan, or corrective action, preventative action. So with that CAPA, it needs to be SMART. It needs to be specific, measurable, achievable, relevant, time bound. So we've talked about all these things already, but that's a really nice acronym to remember. So as Becca said, don't overpromise. So that's achievable component. Is it relevant to the why, that actually like the root cause of what spurred this discrepancy to happen?
So a great thing with that, let's talk about that lab thing we had. If you wrote in your CAPA, the lab staff was re-educated about when they need to send the lab out, they weren't even the problem.
Yeah.
It was the coordinator who didn't tell them. Right. So it's like it has to be relevant, you know. So that's what that relevance means.
Yes. And then you obviously want it to be specific. So specific again to that root cause, who needs to be re-educated, not just say the team will be re-educated. Maybe it's just specifically the coordinators. Maybe it's specifically the lab team, and then time bound. So you don't want to just say you're going to do it and never do it, or wait 5 years to do it. You want to do it in a relevant amount of time. So we're going to go through an inadequate CAPA. It's not SMART. So here's an example. And this is what we see all the time in our office. We help write these CAPAs. But your issue is that a patient left the clinic after treatment and missed several questionnaires critical to the study endpoints. So maybe we're reviewing this CAPA. I see some people smiling, so it just cracks me up. But okay, if you're reviewing this CAPA, you see that's the finding, and they write the root cause is that the patient left the clinic after treatment.
They didn't fill the stuff out because they left.
What questions would you have as maybe the audit reviewer looking at that root cause?
Why did the coordinator let them?
Yeah, why did the patient leave?
Yeah.
Yeah.
What, like, so you might have a couple more whys, right?
Yeah.
And then they write that the corrective action is that the CRC notified the sponsor that the patient left and the questionnaires were missed.
Like, didn't actually correct anything, so
Okay.
they just notified someone.
And then the preventative action was the study team will make sure to get questionnaires completed for future patients. So
Again,
what
not
questions?
preventing anything,
Yeah.
just that
So
will do it better in the future.
What's
Yeah.
your question there when you see that as a preventative action? What are you what are you wanting instead?
What are you actually gonna do to make sure that gets done?
Yeah, like how are you going to make sure?
Yeah,
that
how
this
are you
is
going to
done?
make sure?
Right.
If you missed it once before, you could miss it again. So you have to do something different. You can't.
Right.
Yeah. So
to say the least, this isn't specific. It's definitely not measurable, right? Achievable.
I don't know. We'll see if they miss another one. Yeah.
Relevant. We don't even know the why. So we don't even know if it's relevant or not. And it's definitely not time bound. They didn't say like when people were going to be re-educated or anything of that nature. If they're even re-educating people,
Yeah.
honestly. So Spec is going to go into a more properly written CAPA.
Yeah. So sorry, the font's a little smaller because it's more thorough. So, so again, patient left. The finding again is our same finding. The patient left the clinic after treatment and missed several questionnaires critical of study endpoints. So the root cause now is at the time the participant completed treatment, the study coordinator was unexpectedly occupied with another research participant and was unavailable to facilitate questionnaire administration. A communication breakdown occurred as neither the participant nor the infusion nursing staff had been informed that the completion of the questionnaires was required prior to the participant leaving the clinic. As a result, there was no secondary process in place to ensure that the required questionnaires were completed. So basically the coordinator didn't tell the nurse because they thought they'd be up there, but then they were occupied with the patient. And so now no one knew and no one was able to tell the patient and the patient left. So that makes sense of how that could happen. So now we can figure out our corrective and preventative action plan. So the corrective action, upon identification of the missed questionnaires, the CRC promptly notified the study sponsor of the deviation and the circumstances contributing to the missed assessments. The sponsor guidance, per sponsor guidance, the CRC contacted the participant to determine whether the questionnaires should be completed after the fact, either by returning to the clinic or completing assessments via telephone as permitted by the sponsor. The questionnaires were completed over the phone, and this was documented in the study records, and a deviation was reported as these questionnaires are intended to be done in person. So we did a deviation that the patient left, and we had to complete these via telephone, not that they weren't done in person then. If the study allowed them to be done over the phone, I guess technically if you did them the day you were supposed to, I guess that wouldn't even be a deviation. But according to this situation, they were supposed to be done by the patient in person. So the preventative action. A standardized process will be implemented to identify participants requiring protocol-mandated questionnaires for each study visit. The CRC will communicate questionnaire requirements to the infusion nursing team at the participant check-in, and completion of required questionnaires will be incorporated the workflow using a study-specific checklist. Participants will not be discharged from the infusion area until all required research assessments have been verified as complete. Additionally, a designated backup team member will be identified to assist with administration or oversight of critical study procedures when the primary coordinator is unexpectedly unavailable. Staff involved in the study visits were educated on the revised workflow and the importance of collecting participant-reported outcomes that serve as study endpoints on 6/15/26, and documentation of this education was filed in the study file. So again, it's very thorough, and this
specific.
is very specific. You know, we have that, not that we were going to educate them, but we actually did it, and here's the documentation. So
all right. We're in, guys, we have 2 minutes to spare and 2 slides. So here we go. So your takeaways. You're not alone. Remember, when problems arise, you need to stop. That's like honestly the most important part. I will say stop, assess the situation, act accordingly, report it, and try to think of how to prevent it. So we are all responsible in some way for developing and implementing CAPAs in order for us to be successful and run successful research. These should be done in a collaborative manner. So as Becca mentioned, like you're not on an island. You need to involve others, whether they're involved in the actual issue. Are they the ones that are the front lines who are doing maybe whatever procedures were the problem? Do you need to involve leadership, right? Who all needs to be educated or a part of that process? You have ancillary groups you're working with. So you're not alone. And then keep asking the why, that 5 whys, really get to that root cause so that you can be more successful in preventing this issue from happening in the future. So 5 whys, and remember to write SMART CAPAs, that they're specific, measurable, achievable, relevant, and time-bound.
And these are just the references we used for this, and that was it. That's all we had here. So I don't know if anyone has any questions. I'm like, couldn't have planned that any better. So yes. So
somebody in the chat asked about the slides being sent out. You should have received a few emails, and there's always a box link in there. I can probably drop it in the chat right now, but you can always email me as well, sbeyler@mcw.edu, and I can get those slides out. And then you get another email after this course with the evaluation, and then you'll also get another link to the box link with the presentation. So yes.
okay, great. Well, thank you guys so much. So thank you. Hey, Brooke, are you getting that?
I know. Just looking